Good morning, guys, and welcome back to our course today about the prioritization station and the interview. Should be an easy, quick one, and yeah, hopefully you will enjoy it as yesterday. So we'll follow the same structure. So very quick introductory lectures, and then we will go for mock practice. So we'll start with a quick introduction from Ahmed Hassan about the station. Then we'll speak about the format and structure of the station. And yeah, Mohamed Khalifa will take you through common scenarios for prioritization station. Then we'll go to the mock straight away. Okay, so we'll try to stick to time, so make it a quick Sunday for you. We know everyone is engaged in a lot of activities during the weekend, and we don't want to make it long for you. Ahmed Hassan, it's up to you.
Hello, good morning, everyone. Today we'll be talking about the prioritization station, which is my preferred station out of all the four because that's the one station where the interviewers see the way you think about the cases, and you can actually employ your judgment under pressure and your methodologic thinking. So I'll just share a window. Can you see my screen?
Yeah, we do.
Thank you. Okay, so we'll talk about a few things in this station. So the first thing, the format of the station, what the interviewers are expecting from you and what they are scoring you for. So that's one thing. And then how to go through the station without losing much points. So last year I scored 48 in this station, even though it was long and 12 cases and so on, but it went very well. So I'm going to give you some ideas about this station. So this station is about prioritizing common cases that you are expected to deal with during your work, either in district hospital or in a trauma center. They are not expecting you to manage complex cases or make complex decisions or anything that's not common to deal with as a registrar. So they want you to run a safe on call, prioritize the cases according to importance to the patient, importance to the you prioritize according to the patient requirements, according to the skill set, and according to the space you have in the list. And then you need to be quite calm, even if they try to push you, because sometimes they will tell you that you're running out of time. So you need to be aware of your time as well. And then you need to think one step ahead, which means that you need usually to, if you're seeing a case, for example, there is a case with neck of femur fracture. Don't just say that's a neck of femur fracture, I'll list the patient for fixation and that's it, without asking about history of malignancy or query pathologic fracture. Because I know someone who failed the interview twice because of that question. So you need to get more details about the case as well. Okay. Then there are 5 domains as we did yesterday. So the first one is organization and planning, then judgment under pressure, situational awareness, problem solving, and information gathering in the form of communication. So the common domains in all the stations is information gathering, judgment under pressure, and situational awareness. If you're not good in any of them, you will downmark a lot in about 3 or 4 stations of the interview. So the first one is organization and planning. So what we need, don't jump straight into cases randomly. Don't just start. You can either start by the according to the spreadsheet or the cases they bring you. Like they have 12 cases, go through them one by one. The other thing that some people do, you can go through the first important prioritized one, like life-saving or limb-saving cases first, and then move to the next ones. Personally, I go through the cases from 1 to 12 and then prioritize accordingly. And if you can, I know it's not very easy in this station, but if you can, it's ideal to announce your structure first. For example, if you're going through the cases one by one, just tell them I'll go through the cases and prioritize as I go. Or tell them I'll start by the cases that might be life-threatening or limb-threatening and then prioritize accordingly. I did that last year and it was all right. It only takes 5 seconds to say this. And then judgment under pressure, again, the same thing again and again. So do you want you to be calm, decisive? So they might interrupt you because if you are taking a long time in one case because you don't know where to prioritize this patient, they might interrupt you. So know what you're doing. And also, if they are trying to push you to move forward, try to listen to them as well, because otherwise you might not finish the cases. And you need to escalate appropriately. For a patient, for example, if you have a patient that you might take overnight for whatever, necrotizing fasciitis or something, you need to mention that I will discuss with the consultant, book the patient into theater, discuss with the anesthetics team, and move on. And don't try to do everything by yourself. Don't just try to say, that's also about yourself and the consult. Last year, there was a case, I think it was direct anterior approach for wash out of the septic hip, I think. And I was going to list it for ST7. So I told them I'm going to call the ST7 today before adding the patient to his list to make sure he's happy to do this case. And they said that's all right. And they wrote this in my feedback that I escalated and communicated properly with the team. Okay. And then situational awareness. I think that's one of the one domain that makes a lot of people not get into training, because there will always be something about situational awareness, either which hospital you are in, which level you are working, whether you have X-ray or no. And this applies to clinical scenarios, communication, prioritization, everything. So situational awareness is very important, and just they put things in the interview to mark you against this domain. So if you don't pay attention to situational awareness and you act like I'm by myself in the hospital, I don't have anyone to escalate, for example, because that's a common thing. For prioritization station up to 2 years ago, it used to be that you're the night registrar taking handover from the day registrar, and this means you are mostly by yourself. So you act according to this. And then when you move to clinical situation, most of the people will think like the same for some reason, because in the clinical, they discuss the management as if they are working as a night registrar, but they didn't mention that in the question. So don't assume the situation to be like this. So interpret the current information and see what's going to happen later. For example, if you want to monitor a patient overnight and see if the patient deteriorates, then mention that, because if the patient deteriorates, this will change your prioritization. And that's what the interviewers are expecting from you. And then next domain is problem solving and decision making, which is a core part of this station. So don't waffle. If you want to put a patient on the list at this point, just tell them that's my decision and that's my reason. If you don't think like you have to follow certain order of the list because that's the right order and someone else has the better order than you. No, as long as you can explain why you have put this ankle fracture on the list for this registrar or for this consultant, you just communicate with them, tell them that's the reason of my prioritization. They will be happy with it. There is no standard answer that you have to follow, and if you don't follow, you're going to fail. Okay. And then last domain is communication, information gathering. So information gathering, for example, when you see a patient with ankle fracture on the prioritization list, you can either start by asking questions. Is it closed, isolated, neurovascularly intact? Is the patient in a back slab? And so on. You can ask questions, and the interviewers are usually really helpful in answering your questions. They will try to push through the questions as well. Or you can just say, I'm going to gather information or discuss regarding if it's closed, isolated, neurovascularly intact. So you can either ask them and expect an answer from them, which they will do, or you can just say, this is the information I want to get before being able to prioritize this patient. So one more thing you can do is to categorize cases. So normally, when I was preparing for the interview, I was putting cases into categories. So you can have a look at your trauma take list, for example, in any day in the hospital, and you'll find some cases are life-threatening. So you need to do these cases as a priority. Then you'll have limb-threatening, and then you'll have some cases that are normal trauma that need surgery at some point, but they don't have to happen overnight. They don't have to happen tomorrow. And then you have cases that they put in the list to increase the number of cases and see how you deal with it. And at the same time, they are expecting most of the people to cancel them. For example, if you have a patient with 90-year-old and proximal humerus fracture, and you'll ask them, is it dislocated? They will say, no, it's neurovascularly intact. That's it. You don't need to put the patient on the list. So you'll explain that according to Profer trial and so on, I'm going to put the patient in a sling and bring back to the clinic and so on. So for certain cases, they are expecting you to cancel. So be good in canceling cases like what you do normally. So in the prioritization, when you're putting patients on the list, you start by life-threatening conditions, of course. Unstable pelvic fracture, arterial bleeding, any of these, or venous bleeding needs pre-peritoneal packing, any of these scenarios, patient is not responding and so on. That's your top priority. Vascular injury in open ankle fracture or any of the limb-threatening comes next. And then urgent but stable cases, including open fracture. They need to go to theater, but within 12 hours or 24 hours, so you don't have to take them to theater straight away. You'll have cases like NOF, I'm going to manage according to the best practice tariff and surgery within 36 hours and so on. So these cases are urgent. They need to be done within certain time, but you don't need to do them straight away. So this will come after the life and limb threatening. And then you have cases that are normal trauma, distal radius fracture, ankle fracture, whatever, and the patients are right in a PAC slab on VTE prophylaxis and so on. Then these patients you can cancel, or if you have space on your list, you can put them as trauma normal cases, but not as your priority. And you'll have elective. They always bring something as elective, like total knee replacement, meniscal injury, whatever. So these cases can go. You can just say, I will apologize to the patient. There is no space, and I'll cancel them and discuss in the meeting and so on. One of the other things I used to say whenever I'm canceling a patient, for example, they will say the patient has ankle fracture, the soil check was all right, the patient is ready for theater, was canceled a few days ago, and there's no space on the list. I would say I'm going to call the patient, explain the situation to the patient, and apologize to him, make sure he has appropriate analgesia, and move on. That's it. So they always wrote this as good feedback for me when I discuss or communicate with the patients that I'm going to cancel. So I know I finished the presentation, but there are a few things I'm going to mention. Sorry. Okay. So there are a few things I'm going to mention. So while doing your preparation, so don't start especially the prioritization station, don't start the prioritization station at the beginning of the station. So usually you expect very common cases. So for example, before I start, during these 2-3 minutes, I'm waiting for the station. I haven't seen the cases yet. I don't know what cases they will bring, but I will talk about to myself the way I'm going to talk in the interview. And this makes you start more smooth during the interview. So if I'm now in the waiting room and the station will start in 1 minute, So I'm going to talk to myself, is it closed, like assuming it's an ankle fracture, I would say, is it closed, isolated, neurovascularly intact? Is the patient in a back slab, reduced, good position, and so on, whatever I want to say. So I will say that to myself. And then when I enter the station, I will continue talking in the same way. So it's not just like, you get shocked by 12 cases and you don't know what's going on. No, I anticipate this and I prepare myself for talking. There is one more thing I want to mention is that the categorization of the cases. So they will always bring something that you need to refer to another hospital. So for example, your district hospital, you have a GA3 open ankle fracture with neurovascularly intact. So this patient, you will say, I'll manage according to post guidelines, do so and so, and then discuss with the trauma center or the orthoplastic team and send the patient to the trauma center. If there's coda equina, for example, and you're in district hospital or cord compression or whatever, and you're in district hospital, you don't have spinal team, and then you move this patient, so you get rid of this from your list, so you save yourself space, but also you direct this to the right specialty because that's what they expect from the registrars as well in general. So a few things to make yourself score 4 to 5 in this station. It's not about knowledge. The knowledge is there. If someone hasn't done any like TNO before or did only like 6 months or something, he might struggle in this station because he wouldn't know how to manage certain cases. But normally anyone who's been working for a year or so should be able to score very well. And that's what the CT2s and some CT1s as well has taken the interview and passed without any problems. So you don't need to know the actual management or what to do or how to deal with this exact case. But for example, don't say I'm going to struggle if they bring like complex comminuted pilon fracture because I don't know how to manage it. This you're not expected to manage. You're expected to do the basic things you'll do as a registrar in the ED: put the patient in a back slab, reduce and X-ray and VTE prophylaxis and so on. That's your role, and then this patient will need to be assessed and discussed in the meeting, and the plan will be accordingly. So you don't need to panic if you see something complex that you don't know, because most of the times they will bring one case or two cases that are quite complex. They are not expecting you to do the full management, but at least do the basics, save the life of the patient. If there is prosthetic joint infection, for example, you will follow the post guidelines, and then the management of the prosthetic joint infection or the periprosthetic fracture, for example. That's another common case. If they bring a periprosthetic fracture in the exam and you're not expected to say that you'll do replacement or you'll do fixation or you'll do whatever. So you're expected to know how to manage the patient in the ED, probably get a CT if you need to, or explain why you might need to get a CT scan, and probably put the patient in skin traction, put the patient in the ward, VTE prophylaxis, analgesia, and discuss in the meeting. That's what you need to do. One more thing, most of the times there will be something to go to theater overnight, and this can include necrotizing fasciitis, septic hip in a child, vascular injury, open fracture with gross contamination if you are in the trauma center and you have plastics team. So something like this you need to take overnight. And then there will be cases you need to monitor during the night, and you might not need to take the theater overnight. For example, if you have a patient with prosthetic joint infection, so this came 2 years ago, prosthetic joint infection, and it was very confusing. So you just follow the guidelines, monitor the patient, and if the patient deteriorates or becomes septic, then you might need to discuss with the consultant overnight. But otherwise, you will continue to monitor throughout the night. That's also the same for septic joint. If the patient is not septic, you need to say specifically that I'm going to monitor the patient overnight, make sure he doesn't deteriorate. And if so, I'm going to escalate or discuss or whatever plan. So the best thing I would say for this station is to take it from one point to the other. Don't just crumple all the cases together and say, oh, that's the life-threatening, I'm going to do this case. And then you look at other cases and they're all the same because they're all not very urgent and you don't know how to prioritize them. And that's what happens with most of the people. Everyone will know the life-threatening case and they will say, I'm going to prioritize this case, I'm going to do this patient right now. That's it. And then after that, they don't know how to prioritize other cases. So if you categorize the cases, you'll be able to take it from one point to the other. And then at the end, give yourself 1 minute to put the list. If you don't get through the list perfectly, it should still be okay. I know someone who's ST5 now, and she scored 43 in the prioritization station, and she didn't even get to the ordering the list. But while going through the cases, she did very well. She had very organized plan, and she was doing. They were happy with what she's saying, so they just gave her the good score, which is better than what most of the people will get into the list, but without clear planning. So it's prioritization, know the clinical knowledge, which I think most of the people know, but know how to communicate what information you need to ask. Again and again, I would say, because I know someone who failed the interview twice and didn't get training for 2 years just because he didn't ask about, is it pathologic proximal femur or intertrochanteric femur? If you don't ask the question, you didn't mention it, you're not going to look into it. So that's what they don't make assumptions about your knowledge the same way you don't make assumption that they know that you're talking about it. So if you want to say something, just mention it clearly, and it will take 5 seconds to ask an extra question. So it's not going to waste your whole time. And yeah, good luck.
Thank you, Ahmed, for very elaborate. Okay, I don't know how I'm going to put the exam next time. Okay, you told them all the tips and tricks. But the prioritization station, as everyone said, is to check for certain points. One, are you safe to be an on-call? Okay. Two, your experience in how the UK emergency and orthopedics and trauma system is working in a district hospital or trauma center or a mixed. Okay. Your communication, again, as we said yesterday, communication is tested in every station. And this condition and this station, you are tested on gathering and giving. Okay, so you are expected to, for every case, to ask at least one or two questions about the history, a relevant history, before you make a decision. There's lots of ways to skin a cat, how you prioritize them. But I think the way I like, since I was training, is I divide them into four categories. One is I say, I need to deal with them now. Okay. A bit later, I'm going to ship away to someone else and they are at home and safe. I'll keep them at home. Apologizing for the person who cancelled is very good. Okay. Lots of people miss this. Know your abilities, know where you are, understand the scenario. We don't expect Superman to be in the station who will be flying everyone left, right, and center. And this is why we always give you, there is an SHO with you. Okay, so you're not expected, I'm going to run and call while I'm doing this. No, you can say, well, I've divided the work between me and my SHOs. I'm going to ask them to go and review the NOFs and get some previous history while I'm reviewing this life-threatening condition, for instance. Okay, this is you working under stress and against time. We're assessing how your logical thinking of organization, nothing more. Okay, treating is sepsis. Yes, there's something that you always have to do at night, something that you have to refer to somewhere else. Okay, and something that you will need to cancel. It's not logical to have 12 cases on the list. Everyone knows that. But it just put there to see how you react and how you pick up your cases. There's no 100% order. Okay, there's no two guys will order the list the same way, like the book. Okay, but if you cover your communication, answer proper questions, put a proper strategy, how we need to be discussing every case with me. I'm going to organize them this way. I'm going to do it in this way. I understand your thinking. Then I can follow your full step rather than someone start Don't have good femur. I'm going to do it tomorrow. Then jump to something else. Okay. Tell me how you're going to plan to organize your list so I can follow you, understand your method of thinking. Right, thank you, Ahmed. Any question for Ahmed, guys? Okay, okay, we've got lots of silence. Everyone is waiting and eager for the Viva. Shall we move through for the next speech, Mr. Hashim?
Yeah, it will be Mohamed Khalifa speaking about common scenarios in prioritization. So Mohammed is a post-CCT fellow, HIP fellow in Bournemouth, and yeah, he one of the superstars in this area. So and I'm sure you'll get a lot from his talk. Mohammed, please.
Thank you, Mr. Hashim. Good morning, everybody. I'll try not to repeat what you've already listened to. Give you a few tips, and then we'll run through common scenarios through the prioritization stations. Let me share screen. All right. Can everyone see the presentation?
Yeah, we do.
So just a bit run through what are the examiners looking for or expectation. These are the feedback points, just to echo what was said before. So you have to clarify key questions per case, as I said, 1 to 2 questions. And also you need to show them you take time to check the information given. So there's nothing worse than actually asking a question which is already given to you. So take your time in that. Ask about resources available. These are one of the questions you get asked in the beginning. So where are you? What are the resources in terms of X-ray, time available, availability of extra lists, extra consultants, CPOD lists, all those things. Understand time constraint. So are you allowed to overrun to open another theater? And then you should show what they look for is situation awareness, as mentioned before, logical and progress smoothly. You should show them that you've done this before. It's not your first time, even if it's your first time, but you have to show that you've done this before to plan ahead and progress smoothly. Calm under pressure, and then the key thing is prioritization and decision making. That's the key thing in the last point. So scenarios can be either list planning or can be an on-call shift handover. And don't be worried because it will always be overbooked, unrealistic, and very busy take or very busy list. The common themes that you will always have one case that looks very obvious has to go first. One case might be obviously lost or even cancel the case. And then will be 4 or 5 cases in between. Maybe no right or wrong answer, as long as you justify them. There might be a suggested prioritization order, but most of the time you think you can maybe switch 1 or 2 cases together. As long as you seek clear, logical thinking, that's fine. As we mentioned before, ask about the time, equipment, X-ray, laminar flow, kit. Sometimes operations may not have the kit to operate on shelf. Consultant specialty, skill set. Is he able, for example, to do a total hip replacement? Is he an upper limb consultant and there's a lower limb case and the opposite? Clinical urgency, and then patient limiting factors. Sometimes the patient themselves are not ready, such as patient on DOAC, blood thinners, or patient fed, or patient that need pacemaker check, all sorts of things. So might be a neck of femur that needs to go, but you need to check those things. These are the common themes. So they will have at least 1 or 2 cases, emergency themes, such as sepsis, adult or diabetic, IVDU in a child, for example, Coda equina syndrome or suspected compartment syndrome, neurovascular injury. A children case, usually, whether it's urgent, cold, emergency, they will put your child somewhere in the list. Neck of femur of some description. and they will tell you, or you should ask, even if they don't tell you, what will the time to breach from the best practice tariff, or patient is not ready due to multiple comorbidities. Member of staff, an angry patient, a relative of an anesthetist, also things that to try to put something about conflict of interest and whether you will prioritize these patients even if clinically not urgent, or patient who had multiple cancellations for something cold, for example. Polytrauma, road traffic collision, open fracture, something that will need probably management overnight or transfer to a major trauma center. And there will be some sort of infected cases, whether it's an abscess or patient has potential infection control risk, such as COVID risk, MRSA, for example. And these cases should be either put last or cancelled unless these patients are septic, so should be operated first, but you should be aware that these cases may delay things because you need to clean after those cases or you need to do it somewhere else. Stop avoiding delaying the risk, the list. So I'm going to show you two examples, and then I think we've got a couple more examples if somebody wants to practice or ask some questions very briefly. So that's an example for a theta list prioritization. So I have highlighted the key things. So you are the orthopedic SPR. You will always be the orthopedic SPR. You're not the SHO anymore. You are the registrar covering a trauma list today. So it's a trauma list. It runs full day from 8 o'clock till 5 p.m. Sometimes they give you half day, but this should be running from 8 o'clock to 5. Patients are from the rolling list and they have been starved for operations. So some of patients are starved. So all of them are starved and they were from the day before. Please prioritize these patients, explaining your rationale, and also discuss any specific patient requirements or precautions. So they don't want just you to put the priority order, but you want to discuss and show the thinking process. How did you reach this conclusion? Okay. So that's an example. 45 years old diabetic female. So I've highlighted again that being diabetic with a forearm abscess requiring incision and drainage. Hemodynamically stable. In the real scenario, they may not put all of this. They would say a 45 years old diabetic female with a forearm abscess for incision and draining. And then you ask, is this patient stable, for example? They will say, yes, hemodynamically stable. Or is this patient in sepsis? They will say, yes, hemodynamically stable. So this particular scenario, you don't need to ask more questions. You know somebody is diabetic, incision and drainage, and she's stable. That's it. You don't need to ask more questions. So now you know the priority of this. She's diabetic. So ideally, you want to prioritize the patient. But this patient has got an infection, and she's relatively young. She's stable. So it should be done last. But you should be aware that you should inform the ward, for example, that this patient needs sliding scale. You need to check the BMs of this patient to avoid this patient. For example, if she's last on the list, you told them to give her early light lunch or breakfast, early light breakfast. So you don't need to starve her from like 8 p.m. the day before. So these are the things they look for. So they want to conflict you. She's diabetic, but also she's an incision and drainage. So this is how you should think about it, which is similar to what you do in real life. Okay. If you can do this incision and drainage on a separate list, this is one of the questions you ask. Do we have, for example, a CPOD list? Is there a second list we can just do this quick incision and drainage? Usually most CPOD lists won't mind that because this is what they do with general surgery and other cases. Small, quick cases doesn't need instruments specific to orthopedics. Okay. Next one will be an 89 years old lady with a left extracapsular neck-of-femur fracture. Again, any neck-of-femur fracture has to be operated within 36 hours. As per the best practice tariff. Again, they are all elderly, but they mentioned you a left extracapsular neck-of-femur. Why left extracapsular? Which means you need an X-ray for whether it's a DHS or IM nail. You can ask, is it DHS, is IM nail, but this one won't make a difference. Okay, so you know that this patient needs an operation. She needs an X-ray, and the question is, okay, what are the comorbidities, or is this patient ready for surgery? They will say this patient has got pacemaker. You can ask about blood thinners, for example. They would say you maybe no, maybe yes. and then you can ask, okay, what time will she breaches? They didn't mention this scenario. Sometimes they may mention it, sometimes may not. So these patients will need to have an X-ray availability, and number two, to have a pacemaker check. So you can put her first on the list if they say pacemaker was already checked. But if pacemaker is not checked and you put it first on the list, it's going to delay things. So she can be done, for example, second on the list after allowing pacemaker check. So this is your thinking. You're not yet committed to the order, but this is how you think. And then a child, as we mentioned, 5 years old child with a right displaced supracondylar fracture, humerus neurovascular intact. So you know a child, and he's got a displaced. So this is obviously not type 1. It will be either type 2, type 3. You can ask about Gartland, but it doesn't matter. Since it's displaced, then it needs surgery or reduction of some sort. And he's neurovascularly intact. So you would ask, okay, what? So this is the main question about it. So is this arm pink and has got pulse and perfused? So is it pink and well perfused? Is he comfortable in the cast, etc.? So this will tell you that, okay, he can wait. But however, these cases you should not leave last on the list, even if it's neurovascularly intact, because children, they struggle to fast, they cause problems on the wards. Also, even if it's neurovascularly intact, this can evolve. So you should tell them that you should tell the ward to constantly monitor the neurovascular status and keep it elevated, because at any point it may evolve to a pulseless limb or a well perfused. So he has to go overnight, for example. Okay, but usually these cases can go first on the list, so you can get a small quick case at the beginning, and then, for example, you do the extra capsule neck of femur. Okay, even if it's neurovascular status, but because he's a kid, unless there is a more emergency case, life or limb threatening, in the last 3 cases. So number 4 is a 19 years old male, right foot laceration requiring washout and closure, MRSA. Again, young man, foot laceration, and then he requires just a washout and closure. But they said he has got MRSA, so definitely this will be last on the list, even after the diabetic female, because he can wait. He can be an ambulatory case. He can go and come back. You can even cancel this case if this right foot laceration is not life or limb threatening. But you can ask, for example, how old is this laceration? I mean, is it just yesterday, or has been few days? Is it infected? Is it not infected? So you can ask a few questions. They may tell you some information, or maybe say, okay, this is what you've got. It's just a normal laceration. You can ask about, is there any tendon exposure, for example, is there any blood vessel involvement, if there is skin loss. So because not all lacerations are the same. You can just close it in 5 minutes, or you can spend the whole day trying to suture the tendons and vessels and put a skin graft on it. And then 34 years old male who is COVID-19 positive, sustained a right malleolus fracture 48 hours ago, requiring fixation. So he told you this requires fixation. So you cannot say, okay, I'm going to put him on plaster and cancel the case. So it needs fixation. It's been 48 hours ago. So this means that he missed the initial 24 hours that you should operate before swelling. So you need to ask about swelling. Is this swollen or not? Because he missed the first 48 hours. And also he's COVID-19 positive. Again, there is a higher risk of mortality and complications if you operate on COVID-19 positive patients, the patient himself, but also infection risk to the staff. So you can explore, since it's only 48 hours, you can leave it for extra few days, for example, pending swelling check and pending this patient becoming COVID negative, or at least became asymptomatic if he is still positive, so you can have less risk to staff. And if you operate on those patients, you should know that if you operate, you should allow time for air circulation in theaters. I think it's up to half an hour if it's laminar airflow due to the rapid air changes, or can be actually 2 hours if it's non-laminar airflow. So something like that. I can't remember the exact figure, but you should allow about half an hour extra to allow all of the air potential risk to get out of theaters. And the last one will be a 70 years old female with left distal radius fracture requiring MUA and K wiring. Again, how often do we do MUA and K wiring in a 70 years old female, left distal radius? Again, very rare. Most of them you put a plate or you leave them in cast. So you can say, okay, I will need to check if does this patient really need an operation? And if they say this should be one of the least of the priorities, it can be cancelled, for example, on that day and planned on another day, because you've got too many cases here. So obviously a laceration need to go, an abscess need to go, a child need to go. So So for example, the lateral malleolus, for example, and this MUAK wiring, they could be cancelled. So you've got 4 cases to do. But again, these 4 cases is not probably take the whole day. So you can do one of those. So you can pick, for example, the MUA, do it last, or do it just before the other infection cases. So this should be least of the priorities, for example. But this is how you think about it. So, for example, don't not put her first on the list. If you put her first on the list, people will start raising eyebrows. Okay, why did you put her on the list? Despite being a small, quick case. But the supracondylar need to go, for example. So this how to give you a flavor, what you think about. And this is what you have to look for. They say they score you for that. And this is similar to what they score you. Identify this is too much for one-day trauma. Show initiative to explore other avenues such as CPOD list or canceling case, for example. Identify issues with patients, pacemaker check, diabetic patient, NBM status, need for sliding scale, infection control regarding MRSA, COVID patients. Make safe and sensible decision and explain it. Ask appropriate questions and demonstrate awareness of time period for each operations, including anesthetic time. So how much time you leave for each operation is important. This is another example of a handover list. You are the orthopedic SPR coming to a night shift. So again, you're always the SPR, night shift, district general hospital. The outgoing SPR will hand you over the list of jobs not managed. Please prioritize the task and explain your rationale. And then you can ask any question and discuss it with the day SPR, which is the interviewer. And then there is a consultant on call, which is the interviewer again, would like you to call him for an update. How did you do with this take? Okay. So, female, young, left distal radius ORF today, in pain, requiring analgesia. Pattern recognition, post-operative pain requiring analgesia. Could be nothing, but could be a compartment syndrome. So you should always highlight that you're worried about this patient. I'm concerned that it may be a compartment syndrome. My main concern is to exclude, is this a compartment syndrome or is it just a normal post-op? So you should manage it as a compartment till prove otherwise. So elevation, you split the cast to the skin, okay, optimize blood pressure, make sure the systolic blood pressure is within normal, give appropriate analgesia, but also make sure that this patient has continuous monitoring. As if it's compartment syndrome, so you have to take it overnight, no wait. You have to call the consultant and tell them about that, worried about this patient. And also when you go and see the patient, you don't leave her last. And if there's more urgent case, then you should delegate cases. So this is the other thing. So am I on my own? Do I have an SHO? Do I have an F1, F2? Can help me. So you should explore for those options as well. 87 years old male with intracapsular necrofemoral and ED, breaches in 20 minutes. So again, this looks like a non-urgent case because this patient needs to be optimized for the next day. You can see him later, but because his breaches in 20 minutes, you have to be seen within 20 minutes and then transferred to the ward. So again, you should see, okay, do I need actually to see him or has he had to breach and this is nothing much I can do about it? Or is somebody else, for example, the SHO can go and clerk this patient, to take him to the ward and then I can see him later. So this is how you think about it. Trauma call alert for a 20 years old female, open distal tibia, coming in 10 minutes. Again, you are in DGH. So this patient probably will need to go somewhere else, but again, you need to see them as a trauma call in 10 minutes. So you've got 10 minutes, maybe you can do a quick small job, some few phone calls, and then you go to the trauma case, because obviously once the trauma case here, you should be here. You could not say, okay, I'm not gonna see this case now. Ward referral from medics, diabetic male, painful swollen foot. Again, you're worried about that because the diabetic foot attack, he can lose the leg or he can become very sepsis or unwell. But it could be very early, it could be very trivial, you don't know. So you have to ask this question, okay, is his diabetes under control? Is it really how bad it is, how long it is? Is he stable or not? This is the main question. Is he hemodynamically stable or not? Okay, does he have pulses, for example, in the foot? You can ask a few questions. They may ask you some questions and some not, but this patient will need to be seen of some priority, but you need to check the rest of the cases. Day SHO, for example, clerking a 25 years old male, bimalleolar fracture, needs senior review. Again, it looks like a non-urgent, You need to make sure that the SHO clock the patient, there's a plaster, it is elevated, it looks reduced on the X-ray, and then patient comfortable overnight. You can do him next day if there is capacity, or the day after. He can be even discharged and come back for a pre-planned ambulatory list. So yeah, this one is already under control, so probably will be on the last of your priorities. 42 years old female in ED, acute and chronic back pain. Again, this might sound not interesting, but they say single episode of urinary incontinence. Again, could be nothing, but could be coda equina. So this patient, again, will take priority. Okay. At 24 years old, IVDU. Again, you can ask this question about how is the incontinence? Is it when did it happen? Is it within minutes, or is it like one episode of incontinence a week ago? So that's different. If it's an episode of incontinence a week ago, probably irrelevant, or probably may not be as pressing as you think, but it has to be seen. So you can ask about, did the patient have catheter? Did they do a pre and post operative bladder scan? And sorry, not operative, pre and post void bladder scan. Does she have neurology documented on ACH chart? Is it intact or not? Did she have an analgesia? And the key important things, did she have an MRI? Do we have facilities to do an MRI overnight? So these are the questions you need to ask about. Okay. And then 24 years old IVDU admitted today with a human bite to hand, wanting to self-discharge. Sister wants you to speak to patients. Again, he's an IVDU, a human bite, could be infected, lots of things, ideally need something, but he wants to self-discharge. He's young. You can ask, does he have capacity? Is he aware? Is he in sepsis, etc.? If he seems like he's reasonable and having things, then he said, okay, I will come and see him. He's on my list. However, there are a few more cases that are more urgent, need my time. And he can also delegate. If there another registrar on the ward can see this patient, if there's something else, if there a senior nurse can speak to him. If not, then yes, say, I'm going to accept it, but I have to deal with other cases first. Okay. Again, identify too much for a single person. You can't be Superman. You can't be do everything. Awareness of options, the SHO. So the SHO can clark the bimalleolar and also go and do other things, such as seeing the neck of femur that will breach in 20 minutes. Okay, so the SHO can help you. Identify issues we discussed. Make safe, sensible decisions. Awareness of limitations, so no plastics, no vascular. Appropriate question, awareness of time for each task. I don't know if we have time, if someone want to try it, or shall I just go through it myself, but I've got a couple more scenarios. So this is orthopedic registrar, night shift, DGH, 9 a.m. to 5 p.m. I think probably I will go through this one, show you how it looks like, and then maybe last one, if you've got time, somebody can try to ask some questions. So there's, again, a full list, so 9 till 5, and you ask as a trauma list. This is something similar. So they give you very, very small details, and then you should ask some questions. So 27, let's say this is male, right ankle fracture dislocation. 88, left neck of femur fracture. So you want to know if this open or closed fracture, is it reduced now? And does he have any neurovascular compromise? And how long did the fracture happen? Is it now or then? So these are the questions, okay? You can also ask about comorbidities. Is he diabetic, for example? And they will give you some answers. Neck of femur fracture, again, if this patient, what type of fracture? Is it for a hemi, or is it extracapsular? When will the patient breach? Any comorbidities, especially diabetes, dementia, pacemaker, blood thinners. Okay. 51 male, right tibia plateau fracture. Again, what type of tibia plateau? Is it complex tibia plateau? Is it simple? How old is the fracture? Is there any other associated injuries? Who wants to ask a question? Mina Farg? You want to ask something, Mina?
No, sorry, just because it was written in the chat for the next list. If you want to practice, raise your hand. So that's not for this one. Sorry.
Left supracondylar fracture. Again, like the case we did before. Is it pale pulseless? Is it pink pulseless? Is it pink and with pulse? And what type of supracondylar fracture? Is it displaced or non-displaced? IVDU site abscess. Any abscess, you ask about infection risk, you ask about sepsis, if this patient in sepsis or not. Left tibia fracture for iron nail. Again, even if tibia has not been operated on, so tibia fracture on its own can develop compartment syndrome pre-op. So you should ask, is it simple fracture? Is it segmental open fracture? Is he in compartment syndrome or not? So you should ask these questions about any long bone fracture, especially tibia. Less frank injury, again, it needs to be reduced. So is it reduced or not? Is he diabetic? Is it open, closed? How long? But most less frank injury are a bit complex. Not many consultant orthopedic surgeon will do it on their own. Might need a foot and ankle surgeon, depending on the complexity of less frank. So you should be aware, you should ask about these questions. Pathological fracture of humerus, again, this would be for what? Is it for prophylactic? Is it for something else? Prophylactic nailing, for example, or plating? So you should ask what is the reason for operating. They will give you maybe they give you something about Merrill's criteria, and then you can decide whether this needs to go or not. But most of the pathological fracture, they need workup. So it had this patient workup. Do we know the primary, for example? Has it been discussed with oncology? What is his life expectancy? Okay. Most of these cases need to be discussed in a kind of an MDT scenario. So you should see, this patient have a CT tab, MRI of the whole bone, X-ray of the whole humerus. So these are the things you should ask about. Okay. Yeah. So this is and this is one once you ask, closed, pulse is a bit weak but able to be reduced in ED. So generally you've done the thing, but again, the guidance from GERFT, you should do it within 24 hours. So again, priority to do that, but at least it's not open fracture and it's not, and it's reduced in a good position. Neck of femur fracture, again, for hemiarthroplasty, no medical history, dementia, and breaches 11 a.m. So you could do her on the list, but you can do her second on the list, for example. So first case starts at 8, and this case starts at 11, for example, or 10:30. 51 tibial plateau fractures, yeah, RTC, open, isolated. So again, no other injuries, but it's open. So again, you can transfer this patient. So make sure that this patient had all the post guidance for open fracture. Make sure that this has been done, and then this patient to be sent to the trauma theaters, or to be done within 24 hours if they say, okay, we've got facilities now to deal with it, doesn't need plastic, but this is how you think about it. Left supracondylar fracture, neurovascular intact Gartland 2, IVDU, they give you septic, antibiotic given, not responding. The tibial fracture for iron nail, worsening pain, closed neurovascular intact, again, tells you there could be a compartment syndrome. The less frank is very swollen, but comfortable and needs CT. So again, this case doesn't need to go next day because patient is not ready anyway. And the pathological fracture, it's Merrill 7, again, in pain, mother of anesthetist, but no CT and MRI. So this is just to conflict you, but doesn't need much because this patient probably is an elective case, doesn't need to be operated on. So that's a suggestion of how to prioritize it. So the IVDU, thigh abscess, septic, not responding, this is life-threatening. He would die from sepsis, so he need to go overnight or do something overnight to improve him. So he has to go first. The compartment syndrome, limb-threatening overnight. You have to deal with him second, whether you do a fasciotomy, you put an X-fix, so something has to be done because you can't just take the plaster and leave it without a plaster, okay? And then number 3 will be the supracondylar fracture. This will be the first in the morning. And then the neck of femur, as we said, breach 11 a.m. will be the second in the morning, okay? And then the right ankle fracture dislocation, weak pulses, but closed. So you can do it an X-fix in the morning, and then you check pulses, or you can fix it, okay? And then you've got other cases. I mean, this is probably because, where is the thing? I think it should be 1 p.m. from scenario. That might be mistake because they're only morning cases. That's why I said morning cases. So that's why you don't have time to do the other cases. So and also if you've got time, these patients are not appropriate. So this patient, for example, tibial plateau fracture, you need to go to an MTC. The less frank, cancel because you need imaging and swollen. And then the pathological, you need to cancel and need preoperative management. So again, because this is a morning list, so you got only maybe 2 cases, maybe 3 cases maximum. And then you've got some life-threatening. So don't feel confused Okay, how do I deal with those life-threatening? And also because some of them, because if you say, okay, I'm gonna do the thigh abscess first in the morning, this is not logic. Okay, you can't leave this patient overnight. I'm gonna just cut the plaster and leave it overnight. Again, he could develop compartment syndrome. So this has to be dealt overnight, even if he doesn't tell you that. Okay. Yeah, okay. Someone wants to, do we have time for 5 minutes? Maybe somebody practice this one?
Yeah.
Yeah, Mina can do, yeah.
Go on, Mina. Okay, so I'm giving you this example. You are a night shift, DGH, okay? Receiving, you can read it, just read it. I'll give you a few seconds and then I'm gonna shift to the next one. Okay.
Yeah, so you're in a DGH. I've got a 9 to 1 a.m., 1 p.m. Handover, day situ, following day, trauma last. Consultant wants an update. Right. May I just ask a couple more screening questions? Do we have allied specialties on board, like plastics and vascular in the hospital?
You don't have, no.
No. Okay. And do we have availability for X-ray tomorrow?
You have availability, yeah.
Perfect. Okay. And what is the subspecialty of the consultant on call and the consultant operating tomorrow?
General, I mean, no specific.
General trauma.
Yeah.
That's fine. I'm ready to see the list now.
Yeah.
So first 27 male mid-shaft clavicle fracture. I would want to know if this is a closed neurovascularly intact injury, and I would want to know the timing of the injury as well.
2 weeks old injury, closed neurovascular intact.
Perfect. And has it been discussed in an MDT? Is there was an upper limb surgeon? I mean, does it need fixed at all?
They said they handed you over that the displacement is minimal, less than 2 centimeters.
All right. Okay. So that case may be cancelled. It needs discussed with an upper limb surgeon first. It might not need done at all. And then we'll discuss the order at the end. 77 neck-of-femur fracture. I would want to know the type of the fracture, if is it intracapsular or extracapsular, the time the patient came to hospital, and their comorbidities, mainly their cardiovascular risk, including DUAC and pacemakers.
Patient is medically fit, only take medication for hypertension. She was admitted this morning, and she is for a DHS. And she would breach at 10 a.m. On the next day.
Perfect. So this is the case that I would put for the list tomorrow. I will order at the end. I will consent her for fixation, and she will need an X-ray. And then we have a 76 neck-of-femur fracture. Both cases will need to be treated as best practice tariff as well. So also I would want to know the timing of the injury, the type of the injury, and patient comorbidities, including AMTS and their cardiovascular risk.
Patient is super fit, walks and cycles miles per day, and is independent. I think there was a plan for a total hip replacement.
Total hip replacement. Okay, right. So this is a case that will likely need a hip surgeon or a lower limb surgeon. So I'll have to double check with my team if the morning consultant is happy to do the case. And when was the injury?
Didn't mention, but the consultant said, yeah, put it on the list. I'm going to do a hip replacement.
Perfect. Okay. Right. And then we have a 6-year-old mid-shaft forearm fracture. I would want to know if this is a closed neurovascular intact injury, and I would want to know if A&E have tried to reduce it and put it in a back slab already.
It's a closed injury. They had tried to reduce it. They said the angulation is about 10 degrees, but they want to do it in theater for an MUA. Okay,
right. So you can put this one for a discussion with trauma meeting in the morning, and we can keep them in for observation of neurovascular status. If it is only 10 degrees and they're 6 years old, then there is a chance you can just leave that alone and not do anything about it. So I'll discuss it in the morning with the trauma meeting before listing that child, or with a consultant actually, because it says the consultant wants an update. And then 65 female proximal humerus fracture for phyllos plating. I would want to know the timing of the injury and if it is a closed neurovascular intact injury.
Neurovascular intact. They're not sure about timing. Patient is low function, living in a care home, and she's got significant dementia.
Perfect. Okay. So it's unlikely that we will operate. And is it dislocated? fracture dislocation?
No dislocation, just proximal humerus.
Okay, so that will need to be discussed because that will need an upper limb surgeon to do. And if the patient have low demand, I don't see that we operate on these in the UK according to the ProFair study. So I will not put the patient on the list. I'll discuss it with a trauma meeting, likely for conservative management. 88 years old, left neck of femur on warfarin. I would want to know the timing of the injury and what is the type of the injury, intra or extracapsular, and what is the patient INR?
So patient is for hemi. Patient breaches at 5 p.m. next day. The INR check last time was done was 3. Vitamin K was given, and now the INR has gone down to 1.4.
Okay, right. So this patient just needs a little bit more optimization. I will put them on the list tomorrow, but maybe not fast. I will discuss with my medical colleagues about giving another dose of vitamin K. 1.4 is getting there, but not optimal for surgery. So I'll put them on the list, but likely not fast, to give a chance for a repeat blood test in the morning. And then we have a 45 years old RTC hip dislocation and left femur fracture. Right. I would want to know if this patient have had an ATLS with primary and secondary survey, if other life and limb-threatening injuries has been excluded already.
ATLS done, head injury, very unstable hemodynamically with low HB of 87.
Oh dear. Okay. And it's a native hip dislocation.
Native hip dislocation, yeah.
Right. Okay. So this is a very urgent major trauma case with a femur fracture and a hip dislocation. Are they both on the same side, the fracture and the dislocation?
I don't know.
Right. Okay. So that patient needs to be seen as an emergency. That's the first patient I'll go and see directly after the meeting. That patient needs stabilized according to ATLS guidelines with major trauma, with major transfusion protocol.
So he had 4 units of blood, but HB is still low and his blood pressure is low.
Right. Okay. So that raises a concern about a pelvic fracture that is bleeding. Did we find any other source of bleeding? Is there any in the ATLS? Is there any hemothorax bleeding in the
but
abdomen?
they said this femur need fixing, so that's why he's put on the list.
Right. Okay. So assuming there is no other major source of bleeding, so is it an open injury? Like, is it bleeding open injury from the femoral artery or something, or what's the concern?
Not given.
Right, so that will need assessed. I will go and assess this patient in a resus situation with support from A&E, and then I will urgently discuss this with my consultant on call to consider an X-fix for that patient, or just a direct transfer to the local major trauma center. I need to give my full attention, my full urgent attention to that patient urgently. I'll discuss him with my consultant, and possibly put him on the list for damage control orthopedics intervention, whether it's an X-fix or backing of his pelvis with general surgery support. It just depends on what is causing the low HB.
He's got head injury as well.
He's got head injury as well. So we'll need a CT as well, just to make sure they don't have a major bleeding in their head. Yeah. So they will need a first primary and secondary ATLS survey, and then we will deal with that accordingly with a damage control orthopedic intervention. Yeah. So do we have any further information about the source of bleeding? Was it the femur or the pelvis?
Just move on. You've said what you said. Move on.
And then 8 years old.
This is not a clinical scenario, just
right. Supracondylar ORIF, complaining of pain of the forearms. So the concern here is about compartment syndrome. So on the phone, I'll ask the nurse to remove any circumferential dressings according to post guidance, and then I'll go assess the patient for neurovascular status.
Yeah, the nurse is worried about compartment syndrome.
Yeah, so I'll assess the patient urgently, and then if there is a credible risk of compartment syndrome, we need to operate within an hour from the decision.
So are you ready to give me the order now? How are we gonna?
Yeah.
Patients? Yeah.
So the open femur hip dislocation and the child will need an urgent attention overnight. So that's not for tomorrow. That is for the CBOD list overnight. And then for the cases I will cancel, the proximal humerus and the clavicle fracture will be cancelled. and then we are left with 4 cases. We have a DHS, total hip, and a child forearm. If the child forearm needs to be done at all, I will probably do them fast, not to keep the child fasting. And then I will do the DHS. And then I will probably do the hip hemi, provided that their bloods have come back normal. The total hip replacement needs a hip surgeon to do. So that will depend if we have availability of a hip surgeon tomorrow or not.
So the child compartment syndrome, when are you going to do him?
So that will be done overnight. So that will be done overnight. That's not for the morning. So that will be assessed and taken for theater overnight for fasciotomies.
Yeah, so these are the things. Okay. Thank you very much, Mina. Yeah, so you've done really well. I've got no specific concerns. You'll do fine. You just need to be, as I said, this is not a clinical scenario, so you can ask a few questions, but then just try to move on rather than staying in the scenario. Don't get stuck in the scenario, okay? As long as you've said the right thing, that's fine. I don't know if examiner will prompt you. I try not to, but they may prompt you to move on, but try not to let them prompt you too much. But that's fine. Yeah, so the clavicle can be cancelled, obviously. And then overnight cases, and the mid-arm, forearm shaft fractures, you can accept, or you can do it first thing in the morning, quick MUA only. Probably you don't need TENS for a 6 male, 10 degrees. You can just put a plaster. So this can be done anytime, but you can do it quick in the morning, okay? So these two canceled. You've identified the proximal humerus for the phelos dementia. Yeah, again, canceled. So 3 cases to cancel. Maybe cancel 2 and just do the MUA. So now we've taken those cases off the list. You've got the ITC hip dislocation, again, overnight. Either you deal with it locally or send it to the trauma center. So you have to see, because this is life-threatening. This is a life-threatening, so you identified correctly. And then the limb-threatening is the compartment syndrome, second overnight. And then you've got now the other cases in the morning. So first, the neck of femur breach is at 10 a.m., so you do her first. And then the other fracture on the total hip, you can do them second or third. So let's say second and third. Just INR 1.5 or less is acceptable, so we operate on them. So if it says 1.4, say, yeah, it's fine. Yeah, it's not 1, but you can safely operate on 1.4. So they just need to aware you to make sure you're aware, what is the cutoff point? It's 1.5. It's like if it say you 1.6, yes, you need to do something about it, or 2, for example. But if it's 1.4, it's okay. So you can do her second because she's 88, frail. So and then you do the total hip, for example, last, because he's you might be waiting for a hip consultant, and because it will take longer, and because again, if he gets cancelled or for any reason delayed, he's fit. He can wait another day, for example, even if he doesn't get the best practice there. But the 88 needs to be gone now, and also you don't want to mess with her INR a lot, so you need to get her done, and then you can start her blood coagulation later on. So this is how we think about, do I do the hip replacement or do I do? There's no right or wrong, but this is what you think. Is the equipment available? Is the consultant available? And if everything is available, you can still do this neck of femur first because she's clinically more urgent. She's older itself. All right, well done.
Thank you very much.
Thank you, everybody. I hope this was.
Hi, Mr. Khalifa. I just have one question, if you don't mind.
Yeah, no problem.
When we're giving a list from 8 to 1 or 9 to 1, and in real life, this wouldn't accommodate even 2 cases if we're very efficient. But we still would prioritize at least 1 quick case and 2 DHS and a hemi, for example, and expect that we are not coming across as unrealistic when we're prioritizing the cases.
Yes, but to a certain extent, they plan it from the like theater booking form. So a morning list should be from 8 till 1. So you've got these hours. So 8, 9, 10, 11, 12, 1. So you count the number of hours you've got, and then you've got the number of cases and the anesthetist. Yes, there is a downtime. There is people faffing around, etc. The anesthetist may not show up on time, etc. But they're not going to assess you for those logistical things as long as you've put, so you've got a 5-hour list or a 10-hour list. A 5-hour list, you can get, let's say, a total hip replacement. You give it 2 hours, okay? You give a total hip 2 hours. It might take in real life 3 hours, okay? But a total hip would be 2 hours, 120 minutes. So this is 120 minutes for the hip. And then a DHS, 1 hour, a hemi, 1 hour, for example, maybe 1 hour and a half if you want. And then IM nail, at least 1 hour and a half to 2 hours. So this is how you prioritize things. But if you say a morning list and you do a DHS and a Hemi, and that's the whole morning list, it may be, well, this is what happened in real life, but you can put an MUA, you can put an abscess drainage. So I would, as a rule of thumb, 3 cases per session, 6 in the whole day. But again, they have to be 6 cases or 3 cases that not like 3 total hips, for example, because this is not going to happen. Or 3 iron nails. Again, this is a push. You may not have kit for 3 nails anyway. So just be aware of those things, but don't overthink it. Don't say, okay, yeah, we're just going to do 1 case in the morning. I mean, that's not efficient. They would say, this guy underbooks the list. Okay?
Yeah, thanks.
Khalifa, can I ask you a question, please? Quick question, please. What's the maximum degree of angulation accepted for the forearm fractures?
Well, you can read this in Orthobullets. There's a good table, but again, it depends on the age of the child. So 12 years and plus, it's like an adult. You don't need any angulation. Okay. If it's less than 12, and I think up to 6, you can accept some angulation. They say maybe up to 20 degrees. If it's under 6, you can even accept 30 degrees. But in real life, what we do is you look clinically. If it looks bent clinically, you can justify doing an MUA regardless of the angle. And if it's clinically not angulated and parents are happy, then you can leave it. Okay. Again, if it's like 3 weeks old, there's no point of correcting it. But if it's 1 day, you can do it. So take it pragmatically. Okay. But generally, they won't give you like a number difficult. They would say either 10 degrees or 50 degrees. They give you something very obvious. Okay. Clavicle.
Okay.
Yeah, tenting of the skin, open, 3 centimeter displacement. So it give you something small or something obvious, because this is not a clinical scenario. It's just basically for prioritization.
Oh, thank you so much.
The number I need to remember, it should be less than 10, above 10. Okay. Happy with that?
So the 10 is the cutoff.
So this is how you remember it. Okay. 10 degrees.
Keep it simple. Yeah. Keep it simple.
Okay. If it's 10 degrees above 10, you need to do something.
Okay. Thank you so much. Thank you.
So, sorry, a question, please, if I can ask.
Okay.
You can ask.
Yeah, is a hip dislocation with a fracture femur. If it is in the same side and he has a head injury, so I will be really concerned about the bleeding, coagulopathy, and the head injury. So, is it fair to refer this patient to a major trauma center to be under the care?
Yes. So he has to be discussed with a trauma center and be transferred. So what I meant by first overnight first you're gonna do something about him, whether you transfer him or you operate on him under guidance from the trauma center, because this is life-threatening. He's got head injury, so he might be hypotensive from the head injury. And again, don't say head injury, then there's a blood loss. So he's got a blood loss from the femur and the pelvis, and head injury that is affecting his conscious level and causing hypotension, other sort of things from the head injury, increasing intracranial pressure. So what will happen in these cases in trauma center? So this scenario I've seen him multiple times. Neurosurgeon will take him to theaters, they decompress, and they put an ICP, so to measure the intracranial pressure. In the same time, you're doing reduction of the hip and putting an X-fix on the femur. It's very difficult to reduce a hip with a fractured femur. You can't do it just by pulling in ED. You will need to put the X-fix first, and then you traction on the X-fix. And sometimes you need open reduction of the hip dislocation itself. You might need a hip surgeon who can do a hip approach and reduce it. So they won't get into technicalities as long as you know what you're saying. So he need to have head injury sorted, and also he need blood transfusion. Again, 4 units of blood. Yeah, it seems a lot, but this is nothing. Most patients will need 10 units of blood to stabilize. So he said, give more blood, give more blood. You said massive transfusion protocol. That's fine. 4 is not massive. I mean, massive is you change the whole blood in 24 hours. So 10 units plus. So you give more blood, discuss, ship him to the trauma center. You can put traction on the leg, for example. This is things you can do. So, and then you discuss with a neurosurgeon what they want you to do. They would say, okay, keep blood pressure high, keep it low, keep the head elevated, etc. And then you transfer.
Totally, thanks.
I appreciate it. Don't say I'm going to ship him to the trauma center. Say I will attempt to transfer him to a trauma center.
Okay. Yeah.
Okay. Good. Anyone have any questions for Mr. Khalifa? Good. I think are we doing mock next, Mr.
Okay. Thank you, guys. Best of luck.
Okay, I think
Thank you
Mr.
very much.
Hashem is going to start. Are we moving on mock stations now, Mr. Hashem? He's trying to get someone in.
Sorry, guys. So just engage in a call. Okay, good. So do we aim for a 12-minute break? So 10:30, start the breakout rooms. So it's a quick day, so I don't think we need a long break. So you go grab your coffee, have some stretches, and until I build up the breakout rooms. And we'll go as yesterday. So we'll have 5 rooms. So we'll have one demo scenario. Then every one of you will practice a scenario and have a immediate feedback from the faculty. So first scenario is just a demo scenario, show you how to do it under pressure. Then going forward from this, it will be every one of you practicing a scenario for 10 minutes, exactly like the exam scenario goes, and 3 minutes feedback from the faculty. And they will come back to the main room for feedback, debrief and feedback. So it's up to you. 10:30 will start. So is you're free to stay in, you're free to do, but don't close your Zoom because I need to put all of you in a breakout rooms. So 10:30 you will join the rooms and start. Have a good break. Guys, don't go out because I cannot add you to the breakout rooms if you're out. So you can mute your voice, you can close your camera and you disappear, but you need to leave your Zoom on so I can add you to the chat, to the breakout rooms. And uh, immediately communicate the whole situation with your team, anesthetist and scrub nurse. And once you're done with the operation, your patient off table or safe or whatever the situation you are in clinic or whatever, communicate with your patient, explain, and do a duty of candor if needed. And on a long term, you have to think about debriefing to your team, either at the end of the clinic, end of theater, or whatever, and debrief to the whole department in your M&M or whatever education hub that you have, or the way, whatever the forum you have for doing that. So that's the general structure which you can tailor for every station. So depending on the station, it's a difficult patient, it's a difficult family, it is a mistake intraoperative, it's something missed in the brief, it's a change of operative plan pre-operatively. Whatever the situation is, keep the main structure in your mind and try to tailor it to the situation. So keep in mind immediate action and long-term action, immediate action, safety, communication, and correcting the problem. Long-term action, debriefing to the team, debriefing to the whole department. So you deal with a problem, you act upon it, you learn from it, you learn your team from it, and you keep everyone in the department learn from it as well. So I believe that is the structure which will make it easy for you to tackle any communication skill station, and it's help you in every station, even out of communication, in prioritization, in clinical situations, in everything in the interview, because communication comes in every station. As you understand, and the point is that's the main difference between the other systems and the UK system. And this where we are all weak, and that's why we are today in this course, because communication skill station should be the easiest. It's the hardest because this not wasn't part of our basic training or basic medical school education. So, and that's why you need to train yourself. And that's, to be honest with you, it's not just the interview. You definitely will need it in your specialty training and need it when you become a consultant. Without a proper communication, this is where all the problems comes from. So as a consultant today, I can tell you that you need communication more than you need clinical. Half of your problems are difficult patient, unhappy patient, unsatisfied patient, problem with the staff, problem with the juniors, problem with the residents, problem, corner referrals, stuff like that. So communication is not just a station in the interview, but actually it's a station in your life. So the structure and signposting is important. And the good thing about having a structure and signposting that you can throw it at the start of the station. So he understands that you know what you're speaking about. And you will miss, every one of us will miss. The time is very tight. As you can see, we went through 5 lists today with in my breakout room. We maximum 7, 6, 7, 8 patients. You cannot reach it at 12, which is acceptable. Since you are running logic and understanding that your capabilities and what facilities available and what you don't have, and you practicing safe and logic. So the point, if when you put a signpost, when you put a structure in front of the panel, so they understand that you know what you are doing. Even if you cannot complete it, okay, time restraint is there. They understand that. They know that you cannot go in 10 minutes through 12 patient, clinical and non-clinical, and prioritizing them where to go and what to put on a list. Without a signposting a structure, I cannot read your mind. I cannot know that you know. You need to let me know that you know. When you put a signpost, and you know how to fill it, even if you cannot complete that or you do some mistake in the middle, either I will be helping you as a panelist, or I will be understanding that you know it, but you didn't get the time to complete it. So structure and signposting is important for all your stations, but it has to be proper and you know how to fill it. So, and as again, one more time for communication, it is about immediate action, long-term action, immediate action, recognize, ensure patient safety, communicate with the team, and act upon it if you can sort it. And long-term, debrief to learn from it for yourself, debrief to get your team learning from it, and get the whole department to learn from it. And if you are very, very clever, you can get the whole world knows from it, from publishing like a case report or a case incident or whatever. So I hope this answers your question. And for the prioritization, the point is again, it's about showing me that you are a registrar, you are senior enough to understand what is tricky in this patient, what's risky in this patient. It's not about going in details clinical examination, but the spots you need to spot has to be there. I need to spot this in the history. I need to spot this in the examination. I need to spot this in the investigation. I need to spot this in the discussion. So I know where is the tricky points. Where can I miss? And then go through the list and be very clear. Again, have a structure, either as Ahmed mentioned to you in the morning, either to make it in categories. So that is emergent, that's urgent, that is cold or elective, or to go it one by one and just change your plan with every case. So, oh, this has become now a more priority than the first case. So I'll put it at the first on my list. This is the first one I will see. This one I will go. This one I will delegate to my SHO. This one I will call my consultant. This one, no, I will ask the consultant to come in. So you show me that you're safe, you're professional, you understand what you are doing, you have a high order thinking, you know what is behind the case, and I can get you all examined on the same list with totally different stories because every patient, small tricky point, get it from a cold case to be a very hot case. From a just distal radial fracture, which can stay at home for 2 weeks, to a patient which needs to go now to the CBOT because there is an impending compartment. So keep sensible, keep being yourself, keep being concentrating, ask sensible question to the point, don't waste your time, and always have a structure, whatever the structure it is, but you need to apply it. There is no right or wrong answer. There is proper answer or improper answer. So keep your answer proper to your structure. And keep signposting for me to know what you're thinking about and to understand that you have the knowledge, you have the skills, but time was a constraint. Any question, guys?
Yes, please, Mr. Hashim. Just a quick
Yes.
question to Ahmed Hassan because he literally just
Sure.
in a scenario now. Sorry, bro, I just forgot to ask you about the first case that was borderline hypotensive, 90 over something that you said to me. What shall I do? Shall I take the patient overnight, or does it monitor the patient overnight? If it become hypotensive, take the patient to theater.
Okay, so in real life, in a patient with prosthetic joint infection or septic arthritis or whatever, you'll check the bloods, the observations, if the patient is on antibiotics, and then they will tell you the patient has normal observation apart from temperature of 38 and CRP 100 and white cells of 13, 14. So normally you don't take these patients to theater overnight, but you
No,
monitor
but you
them.
said to me, you said to me that all observation normal, including the temperature. It's just the blood
Yeah.
pressure is. So what?
Yeah, if the blood pressure is 90/60, that doesn't make the patient septic.
Okay, fine.
Okay,
Fine, fair
so
enough.
there is the QSOFA score that you decide whether the patient is septic or no, and whether you say that the patient is in systemic inflammatory response syndrome or no. If the patient has high temperature and the rest is stable, that's all right. If the patient has heart rate of 105, you don't take the patient to theater overnight because his heart rate is 105 and the rest is observation, is normal. So they will give you clear figure that the patient is septic when they need you to take the patient to theater overnight. So it wouldn't be something like this.
Fine, fair enough. Okay, and
Yeah.
for the elective cases, if I've got really
Or what, sorry?
for the elective cases like ACL rupture, meniscal tear,
Yeah.
and I've got a CT2 in an orthopedic theme CST training. If I've got really emergency cases that I have to see myself, can I delegate elective cases to an SHO with orthopedic experience or
Yeah, absolutely. Yeah.
Would
Yeah.
it be reasonable?
Because he's not going to do the surgery. It's if he's seeing a patient who's coming for total knee replacement, for example, he's going to check the patient is marked, consented, and had the bloods and whatever required, and that's
About
it.
examination wise, just to make sure, like Lachman test and these things, is it happy? Will it be reasonable to let CT2 go?
No, you can still send the SHO to do that.
Okay, fine.
Yeah. If the patient is coming for elective, you're not actually in clinic.
Mm,
You're seeing the patients few hours before the surgery.
okay.
So just make sure everything is ready for the theater to go on.
All right. Okay.
Yeah.
Normally, more in a normal day, it will be an SHO assisting a consultant. So he will go through this patient normally. You get my point? So if I'm doing an elective list, sometimes I have an SHO with me. So he
All
will
right.
be the one marking, consenting, and assessing the patient, and he escalates to me if there's something he needs me to do.
Okay. Perfect.
Because whoever see the patient, the consultant will stay see the patient. So the consultant has to see the patient anyway, who he will operate on. But assessment at the start, clerking, marking, consenting, it can be done by SHO because that's the normal practice. So
Okay.
if you are an SHO, you still go and assist the consultant. There is no registrar in between you and the consultant. Yeah.
All right. Okay. Thank you.
Yeah, no worries. Any more question, guys? So I hope everyone has scanned the QR code and have done the feedback. Now that's the time. Anyone still needs a QR code, or you all done?
Can I just ask Ahmed Hassan question because
Sure.
he scored. Have you got any tricks to go through the questions quickly without wasting time, apart from what you said? Just practically something you felt different.
So what I used to do, I've told the people in the room with me. So in my interview, it's 10 minutes, but the interviewer wasted the first 2 minutes reading all the 12 cases to me. And you're in a difficult situation when they do that. You won't be, stopping them and telling them to shut up because you want to start the station. And, there's nothing to do. So you have to just waste the 2 minutes with them. And while he was doing that, I was actually going through the cases and getting a rough idea about what I'm going to do. And then I only had 8 minutes and I finished all the 12 cases. And I had 1.5 minutes at the end to go through that prioritization. So what I do, I plan, for example, if there is an ankle fracture, I would ask them 1 or 2 questions, and then I'll say the management by myself. And in this way, I aim for 30 to 40 seconds per case. So ankle fracture is a closed, isolated, neurovascularly intact. What's the time and mechanism of injury? The patient reduced, I'll check if it's reduced in a back slab, analgesia, VTE prophylaxis, and discuss the management options with the patient. This patient will require fixation. That's it.
Just
So
like one go, you don't wait for answers.
I wait for answers in the first part. So I ask them one question usually because that's the information gathering. So I say, is it closed, isolated, neurovascularly intact? What was the time and mechanism of injury? They will answer these questions quickly, and then you will say the rest of your management. And for the management, you don't need to think about it. Just, you need to just say it straight away. So in this way, I was aiming for 30 to 40 seconds, even before the interview. And even though I didn't know that they will have 12 cases instead of 6, but that's the way I used to practice. So, and if you have a plan for most of the possible cases, you will find a lot of repetitive cases. Maybe 1 or 2 cases would be a bit surprising to you, but the rest would be, you shouldn't take long in them.
Yeah, thank you.
Yeah.
Good.